Good morning, Dr. Greenbaum. Thank you for the question about this large apical diameter. Rather than answer you, I thought I'd do a little video for the benefit of the YouTube channel. So first of all, excellent question. I think it's important that we always try to plan out the attack or the execution when it comes to all clinical dentistry, but especially endo. Make sure we ask the questions. Am I the right person to do this treatment? Do I have the right tools? Do I know what I'm doing? So you definitely had good foresight here, and I do think this is something you can handle. There's just a few considerations that we should probably consider. So this is the image here. As you had astutely identified, the distal root of this lower second molar is rather large. So first and foremost, when do these arise? We often see these with immature apices. It's not too uncommon that a late teenager, early adult will have an open apical diameter on their second molars as these roots are still forming. I'm not sure if that's the case here. I don't know the exact age of the patient, but I do think you had said it's a younger adult. Neither here nor there. There is a large open apical diameter, but I think it's important to know how it arose. Also, we tend to see these with chronic apical infections. Because a root is conical shaped, so is the canal. As we get resorption of the apical diameter, resorption occurs when we have chronic infections, thereby chronic inflammation. That inflammation eats away at the root surface. That's a form of resorption. The apical diameter increases because the canal is also conical shaped, meaning the tip of the conical shape of the canal is more narrow than the coronal sections. So as we get more and more coronal migration of the root tip, we much of the time get an increase in the diameter of the apical foramen. And then sometimes there's just unique anatomical variations, ribbon-shaped canals where two canals meet into one. Honestly, distal canals of lower second molars, we tend to have larger canals and sometimes larger apical diameters, palatal roots of upper first and second molars, so on and so forth. So here are some special considerations, things to think about as we're going about this. When you use the apex locator, it's important to make sure that you're engaging the dentin down near the tip of the canal. That would involve the use of the proper size K-file. It's not uncommon that a K-file will bind up high when you have canals that are larger in an apical dimension than they are coronally. The reason I say this is sometimes you have to open the coronal section to get the K-file to engage at the apex properly so that you get a good reading on the apex locator. So it's important to understand that part of it. I think the most important part is just making sure that you know a 15 file probably isn't going to cut it here. This is probably going to take something on the order of a 35 to 40 in order to get proper reading with the K-file and the apex locator. It's important to know and appreciate the surrounding anatomy. I say that because the IAN runs right underneath here. So it's very likely that the patient had some irritation of their IAN after this endo was done because of the extrusion of sealer. Although we are proponents of small puffs, we are not proponents of puffs when the IAN is sitting right there. So that's something to consider. Just know the anatomy around and change the approach that you take accordingly. The same holds true in the maxillary sinus. Your fundamental principles of endo shouldn't change based on the fact that you have anatomy around, but it should increase the attention that you have to your fundamentals. Take that for what you want. It's also important to know the viscosity limitations of your irrigants. Sodium hypochlorite, which is the main irrigant in endodontics, is rather viscous. If you've ever touched it with your hand, it's rather sticky. High viscosity means that it's not very runny. It's the opposite of runny. In this case here, it's very possible that the size of the apical diameter is so large that the viscosity of the irrigant will not maintain the fluid in the canal. We're very fortunate that most endo that we do, the sodium hypochlorite doesn't go past the apical diameter because the apical diameter is so small compared to the viscosity of the irrigant. It's very unlikely for extrusion of the irrigant to occur. With that said, this is a situation where we're likely to see the irrigant make its way outside the canal. So there's a few things we're going to have to take account for. If the canal is necrotic, because of the fact that your irrigant isn't necessarily going to be utilized in the same way we normally do, where we can apply a little bit of pressure to the irrigant syringe, we might want to consider a two-appointment approach to make sure that we properly clean out the apical quarter of this tooth. And then also appreciating the irritant nature to calcium hydroxide. So if you are to do a two-appointment approach here, understand that calcium hydroxide, if extruded into the surrounding bone, can irritate the bone. It's important to know calcium hydroxide is very alkaline, and the body doesn't like when the pH deviates drastically from its normal pH. That's why it's an irritant. I would not want to irritate this tissue because the nerve is sitting right by there. So if I was going to do a two-appointment approach, I would be very judicious on how I'm applying the calcium hydroxide here, which can be done easily. You just have to think about it. So some irrigation considerations. Know your working length, obviously, but super important to know your working length because you need to control the application of the irrigant and the other tools, because you're trying to appreciate the fact that things are likely to easily extrude out here. As always, use a side-vented needle. This is the time where you want to make double sure that you have a side-vented needle. Do not apply pressure. As you are irrigating, it's not uncommon for the needle to bind on the walls and for us as clinicians to apply a little bit of pressure. Under normal circumstances, that's probably not clinically significant. It's inadvisable, especially under these conditions. So you should be passively adding the irrigant into the canal and not actively applying pressure to the syringe as you're applying the irrigant. This follows suit. Do not let the needle bind into the canal walls. If it binds, then we increase the intracanal pressure. If we increase pressure in this situation, we're likely to get extrusion of the irrigant. This is not a steadfast rule, but this would be a recommendation that you stay 5 millimeters away from the apex with your syringe. So if you know your working length, subtract 5 millimeters, put a rubber stopper on your irrigant needle, and then don't go past that as you're irrigating. That will decrease the chance of extrusion of the irrigant. If you do that, you still need to clean the apical section, so you can use something called paper point irrigation. I don't know if this is actually what it's called. This is just a concept that I have in my head that comes from retreatments where application of chloroform is often used with a paper point, so it's the same kind of concept. What you do is you dip a paper point, clean paper point, into some sodium hypochlorite, and then you insert the paper point to length. You're delivering the sodium hypochlorite to the apical diameter in a much more controlled manner. You do this several times. Each time you take out, you replace the paper point. You'll see that you're actually increasing the removal of tissue in the apical diameter. This is not the same as irrigating with active irrigation. With that said, this might be a situation where you want to consider using a paper point to deliver the irrigant. Consider diluted bleach. So there's lots of literature out there that says 3% sodium hypochlorite is as effective as 6%. Many of the articles that I've read do not adequately dissect out the difference between effectiveness when it comes to tissue dissolution and antibacterial effect. When we're using sodium hypochlorite, it's those two very different functions that we're leaning on. 3% versus 6% does not have the same effectiveness with tissue dissolution as it does with antibacterial effects, which is why we use 6% for all of our procedures. With that said, this might be a time where you have to make a compromise to keep the patient safe. Use your best clinical judgment on whether or not you think diluted bleach is the right play. You might want to consider using other irrigants, such as chlorhexidine. I would be very comfortable using bleach here, just following these other considerations, but something to think about. And lastly, know your surrounding anatomy. That's a very important theme here I'm trying to drive home. When it comes to obturation, there's a few considerations. Use the judicious amount of sealer. Many of us were taught cold lateral condensation, where we filled the canal with sealer and then we pack in as many paper point or master cones as we can, master and accessory cones. In the world of carrier-based obturation and warm vertical, we don't need a whole lot of sealer. As a matter of fact, we need just enough to coat the surfaces of the wall and no more. That's why we use paper points. I put here paper point utilization is key. Typically, with every single case that I do now, especially a situation like this, I will remove as much sealer as I can so that I get the feeling like I've coated the walls, but there's none left in the canal, in the volume of the canal. So typically I will apply a soaked paper point with sealer, and then I remove excess sealer with 4 to 5 dry paper points. What I'm left with is a properly coated canal. In this situation, I would probably go even further and use 6, 7, 8, 9, 10 until I know that there's very small amounts of sealer here. Lots of different ways to apply it, but I think using a paper point here would be the right way to go to control the amount of sealer that you have. We're not looking for a puff here. This tooth unfortunately doesn't set up for that kind of situation. Super important, if there's anything to take away here, do not use Gutta Core. We are fans of Gutta Core because of the hydrostatic pressure that technique affords us. With that said, we're not looking for pressure here. We're looking for the opposite of that. So we want to use warm vertical obturation. As you're doing warm vertical obturation, as with all cases, but especially this one, we want to make sure that we create a solid apical plug with the master cone. What does that mean? Once you're done your instrumentation, your sealer application, and your irrigation, obviously not in that order, you put your master apical cone down. As you pull coronally, there should be a tug back there. A concept I think we all know, but super important that we go over here. It's important to know that that tug back is coming not from the coronal or midsection, but it's coming from the apex. When you do your burnout step, if you don't know what I'm talking about, then maybe we should do a video on warm vertical obturation. But when you do your burnout step, if the apical plug comes out with the hot tip, you did not have the proper size master cone. So resize it. You should be able to remove the hot tip, leaving an apical plug, and then do a really good job of quickly going in there and packing that apical plug. The apical plug is softened. It's softened because you just came out with the hot tip. Immediately go in there with a small condenser and gently apply apical pressure to further seal off that apical plug to create a nice backstop so that you can do your backfill without any chance of extrusion. That's basic warm vertical obturation. So there's nothing special there. It's just very important that you understand that apical plug is super important here. It's always important. And again, know your surrounding anatomy. So some basic Nikkei endo concepts. Have a plan ahead of time. Obviously, you had done this because it originated in the question of what should I be looking out for? Is this a case I should do? So on and so forth. If you have a cone beam, use it before you embark on any endo journey. It's now the standard of care. So we're coming out of this era where clinicians were scared to use the cone beam CAT scan unless absolutely needed. It is the standard of care, if you have a cone beam CAT scan, to take a 3-dimensional image of the tooth before you do it. Do not wait until you run into problems. That's unfortunately still how it's being used. I promise you your endo journeys will be a lot better if you have the third dimension in mind before you do any case. So maybe not number 8 and 9, but really any other tooth I would get a CAT scan on. Warm vertical obturation is a must-have part of any clinician's endo arsenal. It's very common these days for general dentists to rely on Gutta Core as their only solution for obturation. I am a huge proponent of Gutta Core and carrier-based obturation under the right conditions. This is not one of those. So you really need to have warm vertical obturation as part of your clinical skill set. And again, know the surrounding anatomy. That nerve is sitting right there. I wouldn't be scared of it, but I would appreciate it. And lastly, enjoy the fruits of your proper planning and execution. Your patients are lucky to have you pushing your frontier. So I always enjoy when clinicians ask the right questions ahead of time. They get better as a result. Their patients are forever going to benefit from that constant advancement of clinical abilities. So with that said, let me know if you have any further questions, and I look forward to seeing how the execution comes out. If I can help any further, let me know. Take care.